Hello there. Today we are going to talk briefly about healthcare associated infections, hospital acquired conditions, nurse sensitive indicators, and some other complications. So let's get right down to business here. So as you remember, if you think back to the beginning of the semester, we talked about measures and effective measures, and you look at evidence-based practice. And due to complexity, variety, non-standardization, some national forums started to formulate measures that shouldn't happen. And then other regulatory bodies, such as CMS, picked them up, or accreditation bodies like the Joint Commission, or even insurers or third party payers like Leapfrog. So there's many different um, types of organizations that use these evidence-based measures. So one of the very first ones was the hospital acquired condition, or the HACs, as you'll see them call. And they're based on the National Quality Forum Never events. They're things that should never happen. And you can Google that to see what those things are. So the Centers for Medicare and Medicare Services, or CMS, thought this was a good idea. And so they selected some conditions that are high cost or high volume, or both, resulted in the assignment of a case to a DRG that has a higher payment when present as a secondary diagnosis. So when a patient comes in who already has a pressure ulcer, the organization doesn't get dinged for that. But if the patient develops a pressure ulcer during the stay, the hospital gets dinged, or if it's not documented on admission. So there's a lot of data refinement that has to go on with these from a hospital perspective. And lastly, they could reasonably have been prevented through the application of evidence-based guidelines. So CMS set up a plan where the hospitals weren't paid for HACs. And the plan's complicated. So the fact is they may not get some payment for the HACs, but usually the patient's in for other things. There's a lot of comorbidity. So the hospital ends up getting paid usually to some degree, but the hospital may not get certain payments. And the other thing is all of the HACs are derived from coded data. So it's more accurate than voluntary reported data. In fact, for voluntary reported data, most organizations look at the HACs and put them into the incident reporting form because you can't count on things being submitted. And they can represent patient care errors. So they look at falls, routine foreign objects, and other things. And actually, here's the list of HACs that are tracked. So there are foreign object retained after surgery. So if I'm a safety professional or a quality professional, in addition to looking at the incident reporting system, I look at this every month or every week to see if any of this coded data pops up, because sometimes you can find issues, air embolism, which actually happens, blood incompatibility, pressure ulcers, falls and trauma, poor glycemic control, and actually not every one of these is a drug error. However, sometimes they are. CAUTIs, vas cath infections, surgical site infections for certain procedures, DVTs, pulmonary embolism, and then iatrogenic pneumothorax with venous catheterization. And that's more of a complication. It does happen. It's not always an error. It's more of a quality issue. Nurse-sensitive indicators are collected through the National Database of Nursing Quality Indicators, and you may hear NDNQI, and used for magnet designation and quality improvement. So those are thought to be mostly under nursing control. CAUTI, patient falls with injury, pressure ulcer restraints, and pediatric PIV infiltration. Now, the thing is, though, as we know, patient safety is a team sport. So there's other players that are involved, but nevertheless, this is thought to be primarily under the control of nurses, although when you look at orders and polypharmacy and all kinds of different things, it's not just nursing. Now, NDNQI also tracks nursing staffing, staff mix, and nursing turnover. And if you remember looking back to our staffing chapter, these data are compared and looked at. So the thought is if a unit doesn't meet the nurse staffing benchmark and there's some quality issues that needs to be addressed. The hospital-acquired infections are a subset of HACs, and they also include ventilator-associated pneumonia, central line-associated bloodstream infection, meth-resistant Staph aureus, MRSA, and C. diff. So that's another bucket of things. It also can be something that isn't formally tracked through this. Every now and then you'll have an outbreak of hospital-acquired infections that aren't on this list. And of course, you would track that as a nosocomial infection. So for solutions, all quality indicators are tracked by hospitals, and based on results, quality improvement activities are designed. There's one really successful intervention model. It's called the Michigan model, and hospitals in Michigan collaborated on CLABSIs using checklists and bundles. Dramatic results, and all over the country, other hospitals and systems have tried to replicate their success, and nobody's really come close. So when you think back to implementation and some of the things we looked at for the surgical checklist, that comes into play. But nevertheless, these quality indicators and safety patient care error issues can be the source of really good improvement activities. So how do you know what to improve? The publicly reported measures, and think back again to the governance dashboard. So typically an organization will look at all of the things that need to be reported, including patient satisfaction, healthcare error, quality metrics, and decide on improvement activities. And again, there might be some unit-based activities that a unit notices that can be improved as well. But usually from a system perspective, it's looked at from a system perspective, what everybody improves. It can help mobilize resources, but there may be other things to track as well. Now, one thing that is certain is epidemiology can be a wonderful model for improvement. And from an organizational perspective, infection prevention is often grouped with quality, patient safety, and risk. In epidemiology, with the use of standardized definitions and data collection and analysis, is a very useful model for patient safety. In fact, it's disciplined, and when a provider, practitioner approaches an issue, it's advantageous to look to epidemiology as a model to make proper definitions, to collect data, analysis, and so on and so forth. Not everybody uses that discipline, so you would use it to develop your PDSA and to help analyze the data that you see. The National Patient Safety Foundation, which is now IHI, urged that we treat patient safety as a public health issue. And I think that is an extremely useful model. And basically, one of the things that's suggested is we shift the focus from an acute care setting, where patient safety has traditionally been studied, to ambulatory care, long-term care, and other venues across the continuum of care, including the community. So here's a diagram that illustrates that. And it can be things like health literacy, health access, access to care, health equity. I think it's been illustrated very clearly that there's health equity issues as illustrated by COVID-19. So this, I think, is what is to come for patient safety and quality, is to treat it as a public health issue. Uh, One of the problems with public health is, and I think we've seen it, is there's a big crisis and everybody thinks about it, like COVID-19. Then things die down and it kind of goes back to low level until there's a flare up of measles or something like that. But it's our duty to make sure that these important issues are in front of our policymakers, our government officials, so we can move the agenda forward. So I hope this is useful information to you as you think about how to frame improvement in your practice areas.